All right. It says we're live. I'll wait till the little viewer thing. You should be able to see something in the top that says if we have any viewers, but it's not showing yet. So I'll let
But
you.
it's telling me it's playing, so
There you
good
go.
enough.
There's the eyeball. There's the. Do you see the little viewer thing up there, or is that just for me?
That's just for you. It just says that it's playing for me.
Okay, fair enough. All right. Well, usually what I say is once I get 10 viewers, we'll start doing stuff. So we're at 2. So once we have 10, we're going to do what we're doing today is going to be fun. We're going to just provide commentary. Let's just provide some commentary. We've got 3 viewers, so we're almost there. Almost there.
I'd like to ask how you came across this.
I literally was thinking I would like to do some reaction videos because I find them sometimes entertaining. And to be honest, my kids watch them all the time and I just get sucked into it. It's not something I've discovered on my own. But then I'm like, there's probably a lot of education videos online for mechanical ventilation. I'm like, maybe I'll do commentary on like a good presentation by someone who I respect, like finding a talk by Dr. Burchard and like just not commenting on it, but watching it and then like clarifying things. I'm like, well, that'll be pretty fun. And then I randomly saw this education video pop up in my search, and it's by a nursing site called Simple Nursing. And I'm like, oh, let's see what the nurses have to say about it. And I'm like, hold the phone. Let me contact Marco and see if he wants to come on and have some fun. And we'll just do commentary on our own to this. So I'm going to bring up some names here because there we go. Show display names. I have no idea how to change. Yes, I do. Not that people don't know my full name. If they're on my Facebook page, they probably figured it out, but there we go.
There you go. Just so we're similar.
Yeah, there we go. All right. So let's watch this video. We're down to 6 views already. We got up to about 8, but maybe everybody's putting their kids to bed. I don't know. We're at 6.
I'm feeling them. I had to do the exact same thing.
Yeah.
And this is the perfect primer because I'm going into work tonight.
There you go. Are you?
I'll be ready? I am. So I'll be ready and I'll get nice refresher.
Yeah, you're going to learn about mechanical ventilation. Okay, let's watch the video. And if anybody's watching and you feel that the sound is not loud enough, like if you can't turn it loud enough to hear it, or if it's totally drowning us out, let us know. But we did do a little bit of a sound check prior to getting started.
Clearly, they've done a lot of topics.
Yeah, and just so we're not being, we're obviously I'm showing where this video is coming from. It's Simple Nursing. I'm not pretending like I'm not trying to share where it's coming from. This is on YouTube. And it's ventilator settings made easy. And so, yeah, let's keep watching it.
Now for ventilator settings and mechanical ventilation. Mechanical ventilation means that a machine is mechanically giving breaths or ventilations to a patient. And the ventilator is the actual machine that works a lot like an air pump that pumps air into tires on a bicycle.
I'm just going to point out that bike tires have one-way valves, and if we ventilated patients like that, we'd blow their lungs up.
Same way, we're pumping air into the lungs.
I'm pretty sure I did this experiment as a child. Just kept pumping it until
the tire popped. Yeah,
exactly.
Which
and then
is
you
very
learn.
different than normal breathing. You see, in normal breathing, the diaphragm and lungs use negative pressure to bring in oxygen, rather than having it
just oxygen
from
yeah, of course.
It filters out air, which is
nothing comes out of it either, right? It just
the majority of what we're breathing is air, but it's only bringing in the oxygen. Fair enough. I mean, I understand they're trying not to confuse people.
Pressure being pushed into the lungs. Naturally, this PPV or positive pressure is a big danger. It can cause trauma in the lungs with overinflation. This trauma is called barotrauma. So just think breathing trauma for barotrauma.
So instead of thinking baro pressure, think breathing.
Because that's not confusing at all when you're talking about mechanical ventilation, right?
No. I mean, I think I'd be more likely to remember the word barotrauma if you told me pressure, like a barometer. But
right.
I don't equate baro and breathing as the same
that damage to the lungs. And in severe cases, it can even pop a lung if the pressure is high enough. This is called a pneumothorax or a pneumothorax.
I wish it always sounded like that. It would pretty obvious when it happens. Yeah.
I like the pneumo. I've never heard somebody call it a pneumo.
And also all the ventilator settings like alarms, monitoring, modes, and settings. But first, let's cover the most tested topics for your NCLEX and exams.
Just really what everyone's
NCLEX, for anyone that has no idea, it's like a national, it's a national nursing exam.
For their license
First up is
for their license of practice,
which causes a huge risk for trauma, bleeding, and hypoxia, that low oxygen. So it's only performed when needed. Now, the top 5 key points that are most tested, write these down. Number 1, we always suction out, never in. Key terms is never apply suction when inserting the catheter into the...
I mean, I'm not going to lie. If I can see a loogie in the tube, I'm applying suction and I'm chasing that sucker through the tube.
Absolutely. You don't push it.
I may not go down very far, but I'm going after that thing if it's sitting in the tube.
Absolutely. Why would you...
I'm not pushing it back in.
Push it in, and then, okay, now we're at the tip, now I'm going to try to get it. And if we lost it, oh well.
Yeah.
Yeah, no, that doesn't make sense.
Yeah, so maybe overall this is a good tip, but there are definitely times where you're suctioning while going in when you can see something in that tube.
The airway. You like that, did you? Well, click here and get access to over 1,000 fun visual videos, 300 study guides,
I feel a commercial coming on.
And a massive
good old
quiz
YouTube.
bank loaded
this
with
is actually built-in
rationales
commercial for
to test your
themselves,
knowledge.
but I
Neatly
feel an ad
organized
coming
in
on.
our new app. Click here to get started for free.
I mean, you got to give it to them. The
memory
graphics,
trick. Just
not
think,
bad.
To get secretions out, we suction on the way out. Now, number 2,
I like how the suction connects to the mechanical ventilator directly. I think it goes to the expiratory valve.
100% oxygen 30 seconds before suctioning, since suctioning can remove oxygen and secretions at the same time, which causes a huge risk for hypoxemia and even cardiac dysrhythmias. Now, number 4, we avoid suctioning before ABG draws. Huge NCLEX tip here. We have to wait at least 20 minutes, since
I'm guessing
it will
that's a
deplete
common
oxygen
question.
levels and show incorrect results. And number 5, avoid suctioning routinely. Huge risk for trauma. Key term here is acute lung injury. So we only suction when needed. So
I feel like acute lung injury, the term is being stolen right now.
and minimized, right? Like this is pretty much sort of negligent, where acute lung injury is a big deal.
Yeah, like this might cause trauma to the tracheal injury, but to use the term acute lung injury, that's pretty it's kind of stealing it from a very important topic. Having said that, I'm not sure the routine suctioning, the avoiding of it is common practice.
No, and it's actually
should be avoided, but I don't feel like this is practiced by most clinicians.
I think that's a bias you got to break from people, saying like if they could be left alone, leave them alone. It's probably the best thing for them.
I will admit I never routinely suction any of my patients, even during an assessment. If I listen to them, they have to sound horrible, or they have to be coughing, or I have to see some crazy waveforms on the ventilator screen for me to even consider suctioning my patient. Otherwise, I'm going to leave them the hell alone.
I've actually spoken to a couple of patients who have been in the ICU and then extubated after, and from everything that they've went through, number one worst thing for them was getting suctioned.
Yep. So I've heard that before. Yep.
Leave them alone.
Yep.
The key term, routinely. Don't get tricked here. Avoid suctioning routinely. Many students get this wrong. Now, a little side note here.
Not just
Kaplan mentions we adjust the FiO2 when preparing to suction the endotracheal tube. And Hesse mentions a patient with increased ICP, when should suctioning be performed?
Who's Hesse?
When the O2 sat drops because of
Kaplan. I don't know Hesse.
Respiratory
Hesse sounds important.
The key term here states
sounds like Hess.
Increased respiratory secretions.
We have our own Hess.
That's
important.
So before the intervention is done, don't get tricked. Always assess before suctioning.
Okay.
Next is oral care, and the big key term here.
Have we learned a ventilator setting yet?
Ventilator-associated pneumonia.
Apparently, there's a lot of ventilator settings to know.
We have to do 2 key things here, so write this down.
They're making them so easy they're not discussing them.
Every 2 hours. to help mobilize secretions. And number 2, oral care with key term chlorhexidine
Every 2 hours? Is that?
typically followed
So
by
I feel
oral
like that's a
suction.
little
I feel
So
like it's a
common
lot, and
exam
excessive.
question here.
I don't
Is
think
the best
chlorhexidine is
indicators
recommended anymore.
of ventilator
So
associated-
that's actually a good comment. So there was some studies that linked to potential harm of chlorhexidine actually. And then a
Right.
study was just done in Toronto. It was a multi-center, and it was a de-adoption of chlorhexidine. And if I'm not mistaken, I'd have to look up the study, but if I'm not mistaken, they didn't find a difference when they de-adopted chlorhexidine. So they were
Yeah.
expecting maybe to see a difference in patient outcomes. They didn't, which also means that the chlorhexidine might not be doing what we think it's doing if there was no difference using something else. Like, in other words, it doesn't have to be chlorhexidine.
Right.
But I'd have to read the study to know exactly what they were doing.
So I know the study you're referring to. I haven't read it in depth either, but that was exactly it's a de-adoption. So you
Yep.
almost consider, so what are the risks of using it if there's
Yep.
no difference, and is there a cost difference to
Right.
de-adopt it, which I don't think was looked at in the study because it was focused on clinical outcomes.
Yep.
associated pneumonia, that VAP. Select all that apply. So the best indicator
VAP?
for that VAP is a positive sputum culture, a fever over 100.3, and even chest x-rays that show new infiltrates. And a common NCLEX question here is appropriate interventions for a patient intubated on continuous sedation to prevent that VAP, ventilator associated pneumonia. Select all that apply.
Let's see here. Let's see these questions. Appropriate interventions for a patient intubated on continuous sedation to prevent ventilator associated pneumonia. Daily sedation and weaning protocols? Yes. Elevated bed, 30 to 45 degrees? Sure. Oral care? Yep. Hand hygiene? Yep. Clock out for lunch?
I want to say yes.
Yeah, I think so. I think that's probably the most important, actually.
Do you see the underline under
Daily
continuous sedation? Right. So there's time.
Weaning protocols called sedation vacations. Number 2 is elevate the head of the bed at least 30 to 45 degrees. Number 3 is that oral care with chlorhexidine. And number 4, as usual, hand hygiene. Always wash those hands. And number 5, no, that is incorrect.
Ah, shit. I got it wrong.
Then you next.
That's quite the lunch.
Next is NGT feeding and GI ulcers when a patient is intubated. So
have we learned a ventilator setting yet?
Write this down. No,
I don't think I've learned NG feeding during my ventilator class.
I wouldn't even think of
so
discussing
let's be real
this.
Here. A bolus feeding is like taking a beer bong. That's a lot
Nice.
going in all at once. Huge risk for choking and aspiration.
And being drunk.
So we always use continuous feedings to prevent that aspiration when a client is on an ET tube. Number 2 is GI stress ulcers from gastric secretions that burn a hole in the GI tract. So ATI mentions a complication.
There's a lot of people that mentioned these things. I don't know who ATI is now.
Yeah, we got Hesse, ATI,
ulcers,
and Kaplan.
So we typically give acid reducers like PPIs or H2 blockers prophylactically.
So see, we are 6 minutes into this and we still haven't learned a ventilator setting.
The number one thing is a dropping O2 saturation. You must always assess first. So write this down. Auscultate lung sounds. So again, always assess before any intervention to confirm tube placement. If secretions or a mucus plug are the problem, then we simply suction it out. But if it's not and the O2 sat keeps on dropping, then we must use mechanical ventilation with oxygen attached and
does anyone comment that that's not
now don't let
mechanical
the trick you
ventilation?
Here. We do not give high flow O2 via non-rebreather mask since it doesn't provide ventilation or breaths into the lungs.
I feel like that's
and number 2, as mentioned before, is secretions.
Statement.
Then we simply suction it out. And number 3,
you go to set up your patient on high flow oxygen. like no, we don't do that. We don't do that. It doesn't provide ventilation. It's like, but your patient's hypoxic. What do you mean?
Well, they also said high flow ventilation. Here's a non-rebreather, and
yeah,
you tell the RT that, and they said, yeah, we have different definitions of that.
Yeah.
So is that manual ventilation?
Thanks for joining us, Liv. You're the first one to comment. We're just doing commentary on a nursing video about mechanical ventilation settings, and so far they have not mentioned a ventilator setting. We're at 7 minutes now.
A resuscitation bag or an ambu
I
bag.
will continue to
So
ask Marco
naturally,
if they've
bedside
mentioned ventilator
essentials, we
settings in
have
case
to
I
have
miss it.
an extra intubation setup and that bag valve mask or ambu bag, also called a resuscitation bag. So Kaplan mentions essential to have resuscitation bag
But what does Hesse
at a
say?
bedside when a patient is
Well,
intubated.
my question
Now,
is, do
other
they specify to
complications,
put it
as
underneath
mentioned
the
before,
patient?
is a pneumothorax
That's
or
very
that
accessible.
popped lung
Right.
from barotrauma caused by that high PEEP. Huge NCLEX tip here. So
Wait,
write
hold
down
on a
these key
second.
terms.
It's caused just by the high PEEP? I feel like they just threw that in there, you know? Like they haven't even mentioned PEEP yet.
No. And over 60% of students miss this. So problem is,
maybe because they've been told that really plateau pressure is really the bad, you know, kind of the bad thing, or driving pressure. But the PEEP alone.
You can't just throw the word PEEP and then expect somebody to like understand what that means, right?
Yeah. And what is high PEEP? They haven't even defined, they haven't really given the purpose of what PEEP does. They haven't really clarified or defined PEEP, and let alone what high means. Now, I mean, we're at 7 minutes out of 24. Let's see. Maybe they'll get to it.
Over 60% of students miss this. So remember, the pneumothorax is a popped lung from too much positive pressure from that vent, aka PEEP, which ruptures the little alveoli in the lungs, and now air trapping is inside the pleural space.
Way to give
And
PEEP a
lastly,
bad
number
name.
3 is our hypotension, that low blood pressure. Another adverse effect from all that positive pressure going into the lungs, causing pressure on the thoracic blood vessels.
I feel like we
Sort of like
always get the
squeezing
bad
the
rap for
heart
the low
down,
blood pressure.
reducing the heart's ability to.
Did you do anything to my patient? Their blood pressure just dropped. I swear to you. Oh, the best is when you lower the PEEP and the blood pressure gets worse. Like, what did you do? I'm like, I lowered PEEP. And they're like, oh.
And it's always like that until the patient is bleeding. And then the nurse has the idea, go up on PEEP. It's going to help.
Right. They're like, wait, you lowered PEEP, but the NCLEX said high PEEP. Oh, shit. Okay.
Pump, which reduces cardiac output. So less blood being pumped out of the heart for less cardiac output. And this causes blood pressure to drop. Lastly is extubation. So when a
we
tube
haven't even
is
got to a
taken out,
ventilator
we
setting
have a
yet. What do you
high
mean?
risk for airway
Why are you
obstruction
jumping to
and
extubation?
respiratory distress. So write this down. We always use warm, humidified oxygen via face mask.
Do we?
Number 2 is oral care with,
I wish
key term
we
here,
did. But I
oral
don't feel like we do.
sponges. So no ice chips and no oral fluids. We have a high risk for aspiration and airway obstruction. Number 3 is the NPO. So nothing per oral.
Honestly, how many people use humidified face mask? Like I forget OptiFlow, just warm humidified face mask. Like, I think that'd be great if we did. I mean, I think it'd be more comfortable for the patients, but that's not a standard. I mean, so when I worked at St. Joe's, we used to extubate people and we would use the inspiratory limb and the heated humidifier and just put an oxygen mask at the end of the ventilator circuit because we had draggers that had O2 flow.
Right.
So we would do that, and it worked well.
At a very small hospital that I used to work at, you used to have little tiny bottles of that we could attach a nasal prong to that give them
little bubblers, and they don't do anything.
Exactly. That was about the extent of what we had.
I always get weird spam comments from YouTube. You see that comment that just came in from the YouTube? It says vum.today.
I thought that was code for you.
No, yesterday one came on for code. I'm live, my dear. What's up? Hold on, I have an emergency. I'm gonna play this, Marco. You
and lastly, number 4
for a second.
is high Fowler's position.
You might miss the settings.
So make sure the head of the bed is up to maximize lung expansion and prevent.
So I can't pause anything.
Now, 2 deadly risks after extubation. First up is atelectasis and pneumonia.
Okay, I'm back. What did I miss?
You didn't miss the settings, that's for sure.
Oh, damn it. I thought we'd get to the settings.
Is where the alveoli.
Oh, I just see deadly. Hold on a second. Deadly risks. Okay, fair enough.
Not using humidified oxygen, remember. Deadly.
Right.
And traps infection leading to deadly pneumonia. So we must instruct the patient to use the incentive spirometer every hour
Sorry.
in order to re-expand.
Deadly pneumonia. Answer, incentive spirometer. Sorry. I'll just say it right now. The studies for incentive spirometry are not actually that impressive. Yeah. Anyways,
They've been looked at in ICU, in the PACU, in every single type of surgery. It's like it's.
Yeah. I even wrote an editorial. I wrote an editorial about this in respiratory care, actually, because they don't have value.
And open up those weak alveoli. And number 2 is turn, cough,
Can't strengthen
and
an
deep
alveoli
breathe
like that.
to mobilize secretions
Get it
and
to
cough
exercise.
out all
It's
that
not a muscle.
With the
mucus,
ventilator.
which causes the infection. Now, number 2 is the Strider here. We call it the Strider squeak.
Have we learned a ventilator setting yet?
Upon inspiration, indicating a very
No, but we're extubating them,
narrow
so it's
airway.
done, right?
This
We don't need
must
to.
be
Yeah, I
reported
guess so.
immediately because it's a huge
We're almost halfway through
airway
the video.
issue and a medical emergency.
The hope is that the
So
rest of
ATI
the video will
mentions
only be
a
about
Strider
the settings.
following
Yes, I hope so.
extubation,
This is just
we
the
must
preamble,
report
right? We're
to
just
the
we're
provider
like getting you all pumped up to learn
And
about
Kaplan
ventilator
mentions
settings.
extubated from
the hope.
endotracheal intubation 10 minutes prior. The priority assessment finding to report to the HCP.
I feel like they're putting the
is
cart a little bit before the
Strider.
horse, right? Talking
So
about
just think,
post-extubation
a
Strider
Strider
before even
squeak
discussing
is
a
very
ventilator setting,
serious.
and yet
You
throwing
must
that deadly
report
peep
this.
in there
Now, a
just
bonus
randomly.
side note here is tracheostomy care.
Oh, no.
Oh, now
Number
we've
one
trached the
priority
patient.
for
Shit.
a new tracheostomy. We're talking immediately after surgery, fresh post-operative. We must, key terms
But
here,
why?
check the tightness of the ties and use one finger to fit.
I feel like the
under
tube is blocked.
ties. This prevents
This is a bad
dislodgement
idea.
and
I
loss
feel like
of
they
the
jumped
airway.
into trach
So
without
write that
discussing
down.
why they would
The
even need
number
one.
Why
one
do they have the blue
priority
rhino
for
stuck
a
in there?
new tracheostomy returning
true, eh?
from the operating
Or
room.
they're
Now,
pre-bronching
the
the patient.
NCLEX
I don't know.
focuses on things that will kill the patient and other safety topics primarily.
Peep.
So always focus on things that will kill the patient or cause
That's
harm.
morbid.
The worst thing that can happen is accidental dislodgement of this tube, resulting in that loss.
What
of
the hell
airway.
kind of tube is that?
Since the
It has
new
like a
trach
tail.
Placement is very
that's the right
difficult
one,
to
okay.
reinsert
There we go.
because it takes time to heal. So we must check tightness of the
Why
ties
are they including the
to
tube?
prevent that lost
don't know.
airway. That's always the number one priority. So
Trying
don't
to
let
tickle
the
the
NCLEX
tickle
trick
the
you here.
carina.
Priority is always airway. Not performing mouth care to prevent
Like they've jammed a
infection,
bougie down there
and
and
not
just
doing a
left it.
dressing change on this new trach or changing the inner cannula. Many students get this wrong.
It's not in the hole.
So please write it down. Checking
No, it's not.
tightness of the ties means maintaining the airway here. Okay, now what happens if the tracheostomy does get dislodged or pops out? Let's say you're going to check on your patient and you find the trach tube.
Okay, so apparently
sitting
that was
on
a
the
circuit.
bed.
That was a circuit
Oh,
the
The
entire
circuit
time.
right down the inside
Well,
of the tree.
now we have a loss of airway from a closed stoma, and the patient's gasping for air. This, my friends, is a medical emergency. So what's your first
I think it's the
action?
It's an
same
ambulance
tube they
siren.
suction with
Well,
too, isn't
we
it?
need to secure
Yeah,
that
that is.
airway, right? So listen close here. For a mature tracheostomy, 7 days or more,
Okay,
we
they define it. That's
insert
good.
the new tracheostomy tube using a curved hemostat. But technically,
very
we should
invasive.
always have an arbitrator at the bedside.
Yeah, I don't
used
think
to
I've ever used
reinsert.
one to.
No,
And number
Change a
2
trach?
is we cover the stoma with a sterile, occlusive dressing and ventilate the lungs by using a bag valve mask over the nose and mouth. Now, those two steps love to show up on the NCLEX, since this is a life-saving intervention.
I mean, I feel like we'd be jamming
Now,
a
let's just
number
say
6
it's a new
endotracheal tube down there.
I was
tracheostomy.
just about to say that.
Less
I'm like,
than
on
7
RT
days.
exams,
Well, then
that's
we
the right
only
answer,
do
right?
number
You can't get it
2
in.
here,
You put a 6
covering the
tube and you
stoma
ventilate.
with that occlusive dressing, and then using a bag valve mask.
If I would
to
come
ventilate
to a
the nose
room
mouth.
and a nurse would have done
Since
exactly
the
what the
trach
neck,
is
the
not mature
neclex,
enough to be
neclex told them, I
immediately
would take off that
reinserted.
dressing, put a tube.
Lastly, a little side note for
and be on
other
my
key
way.
points. Kaplan mentions controlled mandatory ventilation
Okay, there's
for
a mode.
clients with
Oh,
Guillain
here's a mode.
Barrés,
Yeah, you're right.
which I call ground up berets, since ascending paralysis goes from the feet to the respiratory tract and paralyzes the
So
diaphragm.
they didn't define
cover in
PEEP
another
before
video.
using it.
But since it's
Same
very
way as they're not
deadly,
defining
it's
what
highly
CMV
tested.
is. before
And Hesse
discussing it
mentions a patient with
in the
increased
management of a
ICP
one
has
specific
normal
disease
pH,
process.
Condition. Yes.
increased PaCO2, that carbon dioxide.
Oh, there's Hesse
The
again.
HCP orders
Oh,
an
that's Hesse right there.
increase in respiratory rate of the patient's ventilator. The nurse knows that this change should have which outcome on the patient's ICP? Well, it will decrease the carbon dioxide, which will decrease that ICP via vasoconstriction. You see, carbon dioxide dilates the blood vessels, making the blood acidotic. We call it carbon diacid. And this dilation from carbon dioxide allows way more blood flow to the brain, which increases ICP.
Hello, RT. I think my patient has carbon
So
diacid.
we need to get all that acid out of the
Can you
body
come and help?
by blowing it off.
Are you having a
with
stroke?
hyperventilation.
Are you okay?
Like, get your acid out of here. So hyperventilation puts the patient into respiratory.
Is that a question? Could that be a response on the exam?
Think of panting like a dog for alkalosis. So without carbon dioxide,
I'm not sure any of these are going to help me remember.
Constrict the blood vessels for less blood flow and less pressure to the brain. Now, switching gears here, let's cover all the key ventilator numbers, from alarms, modes, settings, and monitoring.
All right, so where are we in the video?
What I want to highlight is the pretty blue light here. This covers a lot of important numbers.
First and foremost.
Down here at the bottom is the clear, curly stuff, which a lot of lung butter builds up in there.
So far, let's talk about ventilator settings. First, we have the pretty blue light, and then we have the clear, curly stuff.
With the butter on the inside, right? That's so.
Lastly, is the
no. I mean, what they did also forget, which we learned in RT school, is the on button. Right? Yeah. That is a very important thing to know. First thing, how to turn it on.
Yeah. Well, at least they have the big round dial.
Big old round dial here.
Big old
always
round
a family favorite. Oh yeah, you turn this sometimes, and I'm just kidding. This is actually a meme from Facebook, and I think it's pretty funny here because half the time
I thought this guy was being serious.
Works. They just push.
I mean, after the carbon diacid and the
alkalosis, starting with alarms.
Taking him serious.
So we have two types: low pressure and high pressure here.
Two types.
So it's a priority.
I think we have
not pressure.
I think we have several alarms.
As a low tidal volume alarm. Just think of the double L's here. It means L, we have a loss of connection resulting in an air leak. Now, it's typically caused from a cuff leak that's not tight enough, or ET tube displacement, which is very scary, or just disconnection of the tubes.
Or if you're using PRVC, it's your patient's breathing more than the ventilator's giving them support.
And usually with a cuff leak, you're not going to get that alarm. It depends unless you have a leak.
You probably get a circuit disconnect. I mean, you're also going to have a very noisy tube.
And high pressure alarm, also called high peaked.
They're going to blame the PEEP again.
Just think H for high blockage.
Okay.
Anything that can cause a blockage of airflow resulting in peaked airway pressure.
Which would happen in volume assist control, but not so much in pressure control.
Now, this is typically from biting a tube, kinks in the tube, excessive airway secretions like a mucus plug,
but secretions wouldn't cause that.
Which is probably the most common.
Unless you had like a
another common
coughing
one
will do it
is
for
a
sure.
client who fights the ventilator.
Oh, he's fighting.
Oh, he just disconnected everything. He's dead.
Some more serious ones are pulmonary edema, that fluid in the lungs, and pneumothorax, that popped lung with trapped air. This causes more pressure. So really, just
again wouldn't actually
blockage of air
happen in pressure control. You're not going to get a high pressure alarm if you have a pneumo. You're just going to get low volume,
right?
Eventually,
so it would actually be a low pressure
drop.
It would be a low priority alarm.
Well, it would, it would maintain the pressure. Just your tidal volumes are going to drop. So eventually, you'll get a low minute ventilation alarm if it's not coming back. I think your blood pressure is going to drop before you get any vent alarm if you're in pressure control.
Now, Kaplan mentions a client with emphysema receiving mechanical ventilation appears restless and agitated. Priority action
just if they have
high
emphysema.
Pressure alarm sounds. Instruct the client to allow the machine.
Oh, because that works every single time. Stop it, sir.
And a common NCLEX
Let the machine work.
The nurse responding to a high pressure alarm on the ventilator.
All right, let's answer these. Let's see these questions. Nurse responding to a high pressure alarm on the ventilator would assess for which condition: auscultate the lungs for pulmonary edema, Okay.
Okay.
And again, we're going to assume they're on volume assist control because we're just going to have to, or else we're going to fail this test, I think. Biting the tube. Tube displacement. I'm probably going to get a low pressure alarm. Disconnection of tubes, low pressure. Excessive airway secretions, sure. And volume control for sure. Kinked ventilator tubing. Yeah. All right. I don't think they're not throwing any curveballs.
Would assess
No
for
curveballs.
which condition?
No clocking
once
out for
again,
lunch.
think high
I was waiting for
pressure,
that one.
high blockage. So option number 1, auscultate the lungs for pulmonary
Greg just said my
edema.
students will see these
Yes,
questions on
this
their
is high
exam.
blockage.
Definitely stealing them.
Option 2, biting the ET tube. Yes, again, another blockage.
I'm sure they'll be better worded
Now,
on
option
the
3
on
and
your exam.
4
Yeah.
are incorrect. Tube displacement, guys, that's a low
Guys.
leak here, a leaky air. And number 4, disconnection of tubes. Again, we're leaking air. There's no blockage here. And option 5 and 6 are correct. Excessive airway secretions can cause blockages.
Again, so we're at 18 minutes out of 24 minutes. I have still to learn about a ventilator setting.
It's not happening.
We've just learned
Impossible.
about 2 alarms. We heard that PEEP was deadly, causes pneumothoraces, nothing to do with plateau. And so far, every example assumes you're on volume assist control.
I mean, if they could teach modes in 6 minutes, I will be so impressed.
Yeah. And not yet, and only once did it say to call the healthcare provider, but it didn't even say call the RT. I mean, I know the NCLEX is within North America, I believe. It's so yeah, there should be.
And it's only for Strider, right? That's the only time they actually
the only time they call the healthcare providers if they have Strider post extubation,
right,
which we learned about before any ventilator settings.
When you lose a trach, when they extubate themselves, anything like that happens, it's fine. You could deal with it. But Strider, you call somebody else.
Yeah, immediately. All right, 6 minutes left. Let's see if we learn a setting.
And kinked airway tubing will definitely cause a blockage. Now let's cover modes here. The 2 ones you have to know is AC and SIM.
No.
AC is for assist.
I'm sorry.
What are we
And this video is from 2021. I'm sorry.
Say, I'm like, was this made in 1967? What is this SIMV? Oh,
sorry. I can't even. I'm done. I'm dead.
I would fail this exam.
I just died.
I would fail the exam because I would choose the wrong mode.
Oh my God! Sorry.
I'm quite curious as to what they're going to say about SIMV.
I just have to rewind that just a little bit so we can hear it again. I'm that entertained by it.
Tubing will definitely cause a blockage.
Let's turn it up.
Now let's cover modes here. The 2 ones you have to know is AC and SIMV. So AC is for assist control.
Which they call the
This
weaning
means
mode.
Full machine control.
The one that, by the way, in 1994 was shown to be the worst at weaning a patient.
Not only the worst, but it actually increased the amount of time to take to be weaned off. I think there's a Cochrane review about that. Like it's like debunked.
It's so bad.
Over the patient's respiratory
I'm sorry, nurses, that you have to. This is what you're dealing with out there.
rate. So it's 100% machine control, typically used after CPR or even in life support, like long.
And again, they're not even saying like when they say 100% machine controlled. I'm like, the patient can control the rate above the set rate.
Yeah, they could trigger. They could do a lot of things on the vent.
Yeah, I mean, like, yes, the timing, etc. I mean, if you're in volume assist control, they can't control the flow, etc. But it's not 100% machine controlled. The patient can control the respiratory rate above what is set. So even that's a little bit like they don't mention anything about trigger. Again, they have 5.5 minutes left to convince me that they're actually going to talk about ass setting on a ventilator. But so far, we've learned that the 2 most important modes are assist control and SIMV.
Term care clients.
Oh, God.
They come back and say
just
SIMV
think
is the most important. I'm gonna
is for
flip out.
actively controls breathing. Next is SIMV. This is known as the weaning mode. So the fancy word
Oh, I can't.
When the person that invented it thought that it would be the weaning mode.
is synchronized intermittent mandatory
God.
ventilation. Basically, the patient controls breathing mainly, and the machine assists. So think of the double S's here. S for SIMV is S for step down. We're basically stepping away from full control, and we're doing the weaning. We're allowing the patient to take control of their own respirations here.
Oh my God.
Next is all the main crazy settings.
Oh, we've got settings.
So starting with the first one, VT, also known as V4. This is known as tidal volume.
Have you ever heard it called V4?
No, because I'm questioning what is V1 to 3.
Yes. Oh, maybe we're talking about I see lung capacity. Maybe V1 is like FRC. I don't know.
Volume.
Right, but I've never heard.
Now,
I've
I know
never
you're
seen
probably
those
thinking
terms.
Me neither.
What is
V,
V1?
But no, it's VT. So the description is the volume of air set to be delivered with each
800.
breath. So every time a patient takes a breath.
So I'm going to just throw this out there that 6 mils per kilo for the average height male is 450 mils.
So you are doubling.
And females around 350, again, average height female. Yeah. Anyways.
Are they going to talk about barotrauma with 800 mLs?
No, just the PEEP.
500
Just
to
the
800 mLs of air.
If you don't really know what it is right now.
Normal in terms of how much air they get. So the memory trick for tidal volume, just think a tidal wave of air.
Well, that's what 800 is.
FRR.
Yes,
this is our
that is,
frequency
yeah,
of
exactly.
respirations. So just the number of breaths per minute. And just like normal, like your normal vital signs, 12 to 20 is the typical setting here. So the memory trick, just think FRR as freaking respiratory rate, man. Okay, next is FiO2.
God.
It's our oxygen concentration, typically between 35 to 100%. So naturally,
What happened to 22
because
to
no one wants to
35?
go below 35%. This is almost legit. That's pretty common in many places. But yeah, I'll turn that shit down to 21 if I don't need it.
I always.
The more severe the patient is. So the memory trick, FiO2, just think FiO2 for feed me O2.
Not fraction, because it's a
peak.
percentage. You know, that would be too hard.
But this doesn't help me.
These. So I
Feed
would really
me.
focus on this one because
Feed me O2. That doesn't make any sense.
Really, the most deadly complications come from this setting. So it
Man, they're
keeps the
really
alveoli open with
is this
pressure.
why nurses are so scared of PEEP?
Oh, the bias is like ingrained into this.
Yes, this is an extremely biased. This guy hates PEEP, hates it.
Sure. At the end of the respiration,
Something happened with him.
A huge concept is that barotrauma.
He was
in his career somewhere. Something happened.
Yeah, he was asked to wear a mask and they gave him PEEP. Like, you know, when you have people just like breathe on a filter, somebody turned the PEEP up and he really didn't like it.
Which eventually can even lead to a popped lung, that pneumothorax.
Yeah, nothing to do with the 800 mils.
No.
So the
of course.
key point is the
nothing to do with that tidal wave of tidal volume.
No, not at all.
Keeping that alveoli open to push oxygen in and expel CO2 out, especially with ARDS, where fluid fills up that alveoli, which blocks gas exchange.
I think I called ARDS
So for the
ARDS
memory
in my
trick,
first year of
think the
RT
double
school,
Ps.
and then realized it was an acronym.
Pushes open that alveoli. And very lastly is the
kind of
PS.
maintains it open.
Kind of like when you're writing an email and you leave PS. This is
What?
our pressure support.
Naturally.
It pushes air to help with spontaneous breathing. So think PS is spontaneous.
But not a. This is not a mode apparently. Right?
No,
this is a
this
setting.
is part of
helping the patient
SIMV
breathe
apparently.
when
Yeah.
they want to take a spontaneous breath. So a common NCLEX question always revolves around the most deadly complications here. So which complication is associated with excessively high levels of PEEP? And the answer is barotrauma, or even pneumothorax. Remember, a popped lung from too much pressure being pushed into the lungs, or basically this positive pressure
this is
from
so
the
backwards.
vents being pushed into the lungs. That's the worst case scenario. Okay, next
There's
up
been no
is
mention of plateau
monitoring.
pressure.
We have three types: the VE, the PIP, and the PIMP.
Oh, here we go.
Oh,
Some
and
picking
the
some
there you go.
plateau.
Plat. So first up is the VE. This is for minute ventilation here. It's the amount of air delivered per minute. So the memory trick is VE. Ventilations every minute. Next is our PIP here. So peaked inspiratory pressure. This is the max pressure during inspiration. So the memory trick, think PIP is the tip of max pressure. And our last one here is P plat, our plateau pressure. This is pressure applied to hold open the small airways and alveoli before expiration.
Are we assuming that they close and collapse when the breath is done? That's what PEEP is for.
So it gives us these little tips and tricks to remember them, but there's no explanation of what it actually, like, it's a very loose description of what it does.
This doesn't even explain that the plateau pressure is really the alveolar pressure. It's just the pressure applied to hold open the small airways before expiration, and which makes the assumption that before they close again, like, no.
It indicates
Well,
lung
if you're
compliance.
that afraid of PEEP and you're
For
setting
guess
it
so,
at
yeah,
zero,
patients
I
at
guess
lung
setting that shit at
who
zero.
have stiff, hard
deadly.
lungs, the lungs are not compliant. They're stiff and hard. So plateau pressure gently reopens the alveoli by holding it open a little bit longer. So the
I wouldn't really
memory
say
trick,
gently,
think
but-
plateau is a paused lung to hold open the air sacs just a little bit longer. Okay, that wraps
It makes
up
it
for
sound like the
ventilators.
purpose of a
Don't-
plateau pressure is to do that rather than to measure the pressure felt at the alveolar level. Like, that's really the purpose of a plateau pressure.
Get
Anyway,
to take your quiz and
Oh my
download
God.
the study guides. Thank you so much for watching.
Marco.
My question is, would you
Thanks for
pass
watching.
this exam?
I would probably, I think I'd pass the exam, but it would be process of elimination. It wouldn't be because it would just be like, this doesn't make sense, but I guess this is what they want. Wow.
I'm not even sure if I would pass it, because some of the answers that I would choose that are right would be
I guess
wrong.
it depends if you had the option, if the option was there. Like,
Was-
if they had an option for, like, what is the most injurious setting of PEEP, I would choose blood pressure over barotrauma. That's for sure.
This is
But if
clearly-
blood pressure wasn't an option, I'd be like, really? They want me to pick barotrauma? Like, this makes no sense.
I mean, I know some critical care nurses that know ventilation as well as any RT does.
Yeah.
That is clearly the person that did not write this,
Yeah.
and they should have consulted that person, because
Yeah.
that was painful.
I honestly can't believe that was from 2021.
I'd be curious. I'd be curious. We stopped the video, but I'd be curious to see if their bibliography had anything relevant.
Let's see. I still have the. I should still have the.
Always check your references, people.
Yeah, let me. Where is it? There we go. Let me just bring it up side by side again. 1 second.
Our full video and new quiz bank, click right up here to access your free trial. And please consider subscribing.
Well, there's the Kaplan.
Yeah, nursing school. Yeah, there's not a whole lot of good reference. I'd like to know where they got the reference that the two modes they need to know is AC and SIMV.
Oh, that pains me.
All right, so let's have some commentary on the comments. Nurse Mike, your videos are absolutely amazing. I wanted you and Simple Nursing to know I passed my NCLEX today with 75 questions. These videos were the best tool I came across, with no doubt.
So, how many questions did you answer when you had to get your license to be an RT? It is way more than 75 questions.
Yeah.
So I'm a bit confused at that.
Yeah. Your videos are so amazing and simple. I especially love your inclusion of test questions. You're the best, sir. That's correct. Your lecture is organized. You just spoon feed the answers to every exam. Thank you so much, Mike, for condensing material. We have to know this for tests. Your videos are the best. I just want to say you are getting me through nursing school. Your videos are so engaging, and I actually retain the information I need. Thank you so much.
You know,
At least getting some positive comments.
I gotta give it. The graphics are awesome. Graphics.
Oh, the
great.
graphics are awesome. They are fantastic. Well, yeah. The only graphic I really wish they didn't use was the one where the tracheostomy constantly had this extra random blue tube right down into the trachea that was connected to the ventilator. Like,
that could be
misrepresentation, but
You know, that could be changed, but for the most part,
Yeah.
you know,
Everything else,
everything else was
good
pretty
graphics.
good.
Yep. They had a good
But
graphic
if you
person.
give the wrong information with the right graphics,
Yeah.
it doesn't really matter.
My number one YouTube teacher that finally managed to help me get the concept of ABGs right after my hopefully not from this video.
I was about to say they didn't talk about ABGs at all. They said don't do an ABG when you suction. That was about it.
Yeah. Yeah. Well, I'm glad everybody passed their NCLEX exam thanks to ventilator settings made easy. Oh, we got another one of those random YouTube comments. I have no idea. Like, what the hell does that mean? I don't even understand. I don't get it. I don't get it.
I don't know. I assumed it was code for you.
Vom red. The hell is that? I feel like it's code for something, and I'm not. I just like this was the earlier one. Vom today. I don't.
I was having vom. I was having vom today.
Was it vom red? Oh boy. All right. Well, that was fun. Thanks for coming on. We should do this again. That was a pretty easy way to kill 46 minutes with a 24-minute video.
I mean, it was a bit awkward at times just because of the video. You know,
Yeah.
I have nothing else.
Yeah.
But that was fun. We should do that more often.
Definitely. That's that'll be a wrap. Any comments in there? Anybody want to add anything? Anyone that's still here? We got 7 viewers on Facebook. Looks like Greg's got some questions to add to his exam.
You know, I would maybe look over those questions before you give them.
Liv saying, I can't. I think I know what she means. Unhear that stuff. It's stuck in her head now. Here we go. She made the comment earlier. I cannot unhear that now. Yeah, no, that's pretty interesting stuff.
So I mentioned I'm working tonight. I'm not going to give any of these tips and tricks to anyone.
No,
because I would be looked at like a fool.
You're going to use SIMV though, right?
Everyone on patient's going to be. Everyone's going to to be on SIMV, PEEP of 0, and tidal volume of 800.
Tidal volume of 800. Yeah,
absolutely.
There you go.
We'll see what happens tomorrow morning.
Yeah, we'll see how long you have a job for. What time do you start? It's like 8:30.
We do 8 hours, so I start at 11:15.
Oh,
to 7:15.
I thought you were gonna be like, I started an hour and a half ago, but been busy on the computer.
I mean, this does take precedence.
Yeah. Don't forget to occlude the trach tonight.
Oh, that's right.
Just get like a bougie. Just get a bougie or something and just shove it down there.
You know what you could do? What it kind of looked like? I'm just gonna put the suction catheter all the way in, and
then just leave it in there. Yeah,
and then see what happens.
Make sure you suction on the way out, not on the way in.
Not on the way in. And if I see anything, I'm just gonna push it down.
Yeah. Do not suction on the way in. Yeah. All right, Mark, go. All right. Thanks for coming on. I'll let pleasure. You have a bit of you time before you go to work.
You know, we're gonna be doing the same thing in our we time. You're probably gonna go writing. I'm gonna go writing, and that's just how it is.
Fair enough. All right, man. Take care, and I'm gonna end the broadcast now.